Yeah, we're going to cover a lot of stuff today. One of the things that brought this course about was just to see how much visibility high-level disinfecting devices has within the hospital, because it is a central component to all ultrasound probes for sure. And that's what we're going to focus on today, is what that interaction is at a bunch of different levels. And so you'll get some really good practical information to be, because of the size of the class. You know, if you have any questions, just feel free to shout them out, or observations about what goes on in your particular facility. That would be useful as well. We're going to cover a number of issues. Haha, that's why she doesn't leave.
Gotcha.
Does it have a timeout on it? Is that why? Okay.
There you go. You should.
Cool. Okay. So here are just a few things we're going to cover this morning. A historical overview of cleaning, how it all came about to begin with, both low level and high level types of disinfection. There are other things that are bookends for those, and that's just cleaning the device, hand cleaning the device itself, and getting off all the macro crud that happens to be on a probe. And at the other end is sterilization, which there is sterilization requirements for some types of probes depending on their intended use. But we're going to really zone in on where the majority, if you looked at a Gaussian curve, the majority of the probe interaction takes place with high level and low level disinfecting devices. And where probes fall into these categories, we'll go over the Spalding stuff just briefly. Again, it's we only have an hour, so we can't really dive into anything at an extremely deep level. Here's something you're going to want to know. You probably already know this: bugs are hard to kill, and they will show up in the least expected places in any device that you're trying to work with. And so we're going to talk about that just briefly as well. And then points to consider: automated, in your facility, do they use an automated device, or do they do a manual approach? Is there a hybrid? How does that actually work? And what are the advantages and disadvantages of the devices that are currently on the market to be able to carry out this important function? Servicing and PMs, what to watch out for, saving probes from early death, and then lastly, some of the key takeaways. Okay. So going back to where the divisions came from, are you familiar with Spalding? Anybody in their stuff? Okay. It's been around a long time, 1957. And taking a really careful look at patients' risk of infection while they're in hospital. I mean, most of you who are students of history or something along those lines know that prior to antibiotics being used, the number one, if you got sent into a hospital, you were more likely to die from something you got in the hospital than you were from your original malady. So it really started taking, we got to take a look at all the devices we're using and what's being treated, what the indications for use could be. And you can see we went from complex versus simple reusable devices with the disinfecting thing, from scalpels all the way up to now we're doing high level disinfecting on transesophageal probes and other really complex types of devices. And they wanted to tie the classification, and I think this was brilliant, obviously, that they did a good job thinking this through, for critical use devices versus semi-critical use devices versus non-critical use devices. They say there's no spandex approach to this. We don't want to high-level disinfect everything or sterilize everything. So there's got to be some stages here where the device that we're using isn't necessarily going to come into contact with anything other than, let's say, skin that is not cut up or anything along those lines. So from that, they would look at the intended use, and they would look at cleaning, disinfecting, and sterilization pyramid that you see here, patient's risk of infection, and then future sustainability of the processes that are going on right now. This is just really show you where some of the things are coming from. AI has been talked to death, but AI touches into this arena as well, using AI to determine a highly accelerated use and when that device may cross a threshold into being wanted to be used for or cleaned differently. So pyramid of increasing microbial resistance is something that drives the FDA into determining their guidance to original equipment manufacturers how your device should be explained in the operator's manual. They call them the IFUs, and how you should do that. And you see a hierarchy start to come down, and so susceptible, resistant, overview of the bugs and how tough they are to kill. And so people or OEMs who manufacture the automated tests or cleaning devices, high-level disinfecting devices, have to kind of determine based on the indications for use what the likelihood is of one of these bugs showing up anywhere on that device when it's used according to the OEM's intended use. And then it goes into which ones are really bad and which ones can be killed off fairly easily. I think everybody remembers the HIV era when it first started happening. Those things would die if you looked at them. Okay, and all the way up to bacterial spores and stuff, and very difficult to kill. So looking at that and looking at how long they live, what's their natural life cycle too, all went into determining what type of process needs to be done in order to ensure that the device is safe to use on the next patient. So some of them live up to 7 months, some of them live 3 days, like the HPV, some up to 4 months. So it all goes up into that arena. And safe to say that patient deaths have been associated with both endocavitary and external ultrasound procedures. So we think of ultrasound as a safe device, right? And it is safe from the perspective of it uses non-ionizing radiation. It typically, so you can use it as many times as you want, but there's another safe that goes along with it, a couple of other safes that go along with it. One is cross-contamination. Are you using it on one patient, not cleaning it or disinfecting it appropriately, and then using it on another patient? This stuff happens. It's not theoretical, it really happens. There's a bunch of I just printed out one page off the FDA website of MOD reports saying here's things you guys got to look out for. Here's an incident that occurred at our hospital. There was a patient died, or the patient had some sort of an adverse event that occurred with it, and it ties into the automated probe devices as well, probe testing cleaning devices. So, and it shows what patient depths from Hep B, and it's not just ultrasound probes. I'm sure you've all heard of the endoscope probes that have also can be a source of cross contamination. So they do happen. It's real. They're published every month on the MOD database, and alerts that the OEMs typically send out to the clinical end users. So it really starts off with the FDA document that says, okay, here's the reprocessing medical devices in healthcare settings, validation methods, and labeling, okay? And so this starts, the OEMs use that, and then they, in their IFU, instructions for use, well, here's one for a probe from Hitachi, and it goes in here and tells you each one of the probes, how they're supposed to be tested based on their indication for use, what chemicals have been validated to render them disinfected, et cetera. And then you get into the practical world, well, where the clinician and the sonographers, the ones who actually do the studies, think this is overkill in some clinical uses, so they want to do it a different way from the way the FDA does, but that can lead to a lot of extremely interesting things happening to probes to the point of just blowing them up. So we'll take a look at that and see some examples. It'd be kind of fun for us, not fun for the person who's responsible for it. You know, again, and take a second just to say, HTMs are the guardians of the gate for technology coming in. You are the thin blue line between safe use of a device and devices coming in and out of your facility, coming in for the initial installation, but also then going out maybe for repair, coming back in. It's supposed to go through HTMs, and so it's necessary, really, I think, for all of the people who are involved in this to understand what's expected of them and how to really think through how I'm going to manage this device while it is in my facility. Okay, so who decides how HDL reprocessing should be done on ultrasound probes? Well, again, the FDA ultimately is responsible for developing guidelines that the OEMs have to follow, and the OEMs follow those. They can't deviate from those. So if a hospital says, can you recommend a different way of doing this? And the answer is no, because that would be against the FDA guidelines for which that OEM has received their 510K to sell the product. But they can't help themselves. Physicians like to meddle in pretty much everything. The code goes on in the hospital, rightfully so, I guess, in some circumstances. But you can see the AIUM, which is the American Institute of Ultrasound and Medicine, has their official statements. It's a guideline for cleaning and preparing external and internal use, et cetera, and also coupling gel. We do a lot of testing at our facility as well on gel. Because you're using gel, if you don't clean it off correctly, that gel is going to pick up whatever it has and go to the next patient. You can't just think you're wiping it off and all's good, or wipe it on your shirt, whatever. I know you wouldn't do that, but some people do. And so, but then you can see the Society of Diagnostic Medical Sonographers has their own guideline, and the Joint Commission has their own stuff. So really, the OEMs are stuck because of what the FDA requires. How medicine is practiced within a hospital isn't regulated by the FDA, but if something happens to a patient because of a medical device failure or cross-contamination or stuff, the FDA does get involved. So there's good reason to understand all these things and how your hospital addresses all of these issues. Again, it showed the one on the left. The OEMs, who decides? Well, the OEM decides the design. And as you'll find out, what is the OEM actually testing? So when they test chemicals that they want to validate with their probe, they don't test if it's killing germs. That's not what the OEMs do. They test, does our material, is it compatible with this chemical? Because you don't want the thing turning yellow, the cables, or you don't want the plastic to start eroding and stuff like that. But they don't test the bugs. That's entirely the responsibility of companies that make the glutathione and other chemicals that are going to do that, and they have to demonstrate objective evidence that it kills it up to the level that the FDA requires for that particular indication for use. And then they go through a real long, laborious process of getting a 510, getting the clearance for their products. So the automated device manufacturers also have to follow that stuff too. So they have to work with the OEMs of the probes in demonstrating to the OEM that our automated device is not going to break anything either. It sounds funny, but you use the same chemical. The chemical is cleared for doing something, but once you put the clinical into a tub, it becomes a different device. Okay, and then once you put it into an automated thing, it becomes a different device. So the manufacturers of the automated cleaners have to go through a process where they intentionally soil the probes, send them out to a facility that tests for those things, and they have to meet a real high threshold before they can sell their product too. So those things all come together. So where do they specifically land in this? And this is in the original equipment manufacturer's documentation. Well, OEMs are required by the FDA to publish these validated reprocessing instructions. It's the responsibility of the device user community to follow these instructions. Using chemicals or disinfection protocols for reprocessing, they're not listed in the OEM's instructions, can and has resulted in some cases cause irreparable damage to the transducer, okay, and has been shown to also cause a compromised ultrasound study. So the FDA recognizes, like I said, then they go through and recognize sterilants and HLD disinfected, and there's just a little list of them right here. And each one of those, so when the original equipment manufacturer of the probe is selecting materials that they're going to have for the housing, and the housing and the cable and the lens material on the front of the probe, they have to take into consideration and they have to validate if they are going to be able to survive in this chemical environment with the printed instructions for use from the chemical manufacturer. So there's a lot of this interaction going on, a lot of Venn diagrams being drawn up and saying who's responsible for what. But ultimately, once it's inside the hospital, I submit that the HTMs are extremely important in guiding how it's used, making sure that it's being used properly, making sure that it's getting the right treatment when it needs to be repaired, etc. One of the reasons is you're watching out for your probes. We see at our facility, we repair hundreds and hundreds and hundreds of probes every month, okay, at Esoterra. And we have probes coming in from hospitals that clearly have been subjected to chemical processing that either killed a transducer or made it look very, very different than what the OEM had hoped for over the life cycle of that probe. And sometimes it's irreparable damage. So, and I'll show you again a couple of examples of that, but have to go through all of those things, not only the chemical, but also the protocol that the chemical manufacturer puts on there. Let it soak for 15 minutes at 4 inches of depth, you know, with the sun out. I don't know. There's a lot of different things that go into that, but you have to read that and make sure that not just using the right chemical, but they're following the right protocol as well. Does that make sense? Okay. So those are all there. And you know, all these slides will be on the MD Expo website, and you can download anything that you want on here. So it's not only the chemical, but the protocol. And here's kind of what that looks like in a chart that the OEM provides. This happens to be from a Toshiba, but it also says time in solution, environmental conditions, is it too hot or too cold in the particular room, and the strength of the solution. Any of those things, all of those are identified as to what it should be and to make it safe. So if any of those change variant from, especially a lot variant from time in solution, we've seen probes that have been put in the correct solution at the end of the day and let to soak overnight when it was only supposed to be in there for 15 minutes. And it looks radically different in the morning than when they put it in. So remember that it's not only the chemical, but the protocol of using it, and the protocol for using it's going to take into consideration time in solution. environmental issues. I mean, you might have to have it under a hood or something, depending on if it's the person doing the cleaning, if they're doing hand cleaning or smelling that stuff, it kills them after a while, and they don't like that much. Okay, and also the strength. Okay, so here's what you'll see in the IFUs from the probe manufacturer. Use of a transducer cover does not change the Spalding classifications. Some people say, well, with the endocavitary probes, and the physicians make this argument, with the endocavitary probes, we put a condom, a sheath over that before insertion into the patient. So it really shouldn't be, it's not touching anything. It really shouldn't be subjected to the requirements that the FDA said for high-level disinfection. But the issue is the FDA maintains and has objective and empirical data to support this, that those sheaths tear sometimes while they're inside the patient. Then there is contact. So therefore, because it's a non-zero risk procedure, you have to do high-level disinfecting, even if you use a sheath. And there's a lot of pushback on that from the medical communities. I've been doing this for 20 years and I've never seen that once. Great. As a physician, you ought to know that one, you're an anecdote, you're not data. They're looking at actual data over a bunch of people. So maybe you were fortunate enough not to have that, but that's not what the FDA thinks. So perforations can and break open and tear, and they do. So how do they select the procedure class and reprocessing procedure for an ultrasound probe? Well, this again is from the AIUM, American Institute of Ultrasound and Medicine, and they take a look at here's all the things that you should do. Here's what determines whether or not it's an internal transducer procedure, whether or not it's external transducer procedure with unbroken skin, all those things, and it'll go through here and tell you what you need to do all the way down to the procedure level. And this also applies with with automated, whether you're hand cleaning or if it goes into an automated device, this type of structure needs to take place. This is going to shock some of you. I've given this talk to sonographers, and they don't always read the instructions for use on devices. I see some smiles out there. Yeah, so that's one thing to make sure, but you should absolutely, when the system comes in, is going to be placed into service that can kill a patient, basically. You guys should be the ones that say, this is what we need to do. Is there a process and procedure in the clinical lab for following? Okay, have they at least seen it? Is there a chart on the wall like this one? That's a chart, just as a reminder, right? That you need to think through these things, and then that'll determine how to clean it. So again, here's out of an OEM. They say always follow the manufacturer's instructions. Because of the large number of available cleaning and disinfection products, it is impossible to have an all-inclusive list. So that the OEM is not going to go through and test every chemical on the market, because there's billions of them, maybe less, one less than a billion. And then if you're unsure of the suitability of a particular product, they say, please contact, in this case, Philips, a representative, for more information. So if somebody wants to use something different than what's listed, they should contact the OEM and not just say, well, it says here it kills bugs, so let's use that. During COVID, some of you know this, probably all of you felt it at one level or another, there were a lot of layoffs of people workers in hospitals, and a lot of them came from the central cleaning and stuff like, oh, well, we're not going to be doing any procedures. We don't need to have instruments cleaned and stuff. So they laid off a bunch of cleaning people in central processing. And what happened then, it was up to the OEM, because ultrasound was being used during COVID for lung. Okay, that was the primary diagnostic tool for looking to see if the lungs were going south, and the treatment had to be ratcheted up dramatically to have any chance of saving the patient. So ultrasound was used, but then the sonographer is going, walks down to central processing and there's nobody home. And I'll show you some examples. And Mark, you've seen some of these too. What happens is they just kind of look on the shelf and say, and read the label, but didn't read if it was validated by the OEM for that, okay? So here's the thing in a GE when really you need to wrap your head around. The GE does not substantiate the effectiveness of recommended disinfection or sterilization products, okay? Questions regarding efficacy, instructions for use and proper handling should be directed to the disinfectant manufacturer. GE does publish a list of material compatible disinfectants. Do not use non-GE approved disinfectant products that have not been evaluated by GE for, look at this in your head, material compatibility. They're worried about their probe getting destroyed, right? Rightfully so. I mean, that's, here's a precaution we need to know. Damages linked to the use of disapproved chemicals are not what? Not covered under product warranty or service contracts. Okay, so there again, you guys come into play, because if your hospital is not following these instructions, your bill for probe maintenance over its life cycle is going to go up fairly dramatically. Okay, so keep that in mind. And testing. Okay, so once you test, or once you clean the probe, there's a before soaking and after soaking electrical leakage testing that needs to be done on the probes too. Has something happened to that probe? So if it passes pre-soaking and it fails post-soaking, and it's an automated disinfecting, something happened to change the functionality of the device, or more likely, it's customer misuse. Okay, getting in a hurry, instead of placing something in like this, they can treat it like a rental car and jam it in, and there's things in there that that can in the electrical leakage that can tear the skin on the probes. So, and then the other thing that a lot of the companies do, and we do this for them, is probe element tests on there as well, before soaking, after soaking. Why is that? We want to, you really want to make sure that there's no leakage in the lens, because right behind the lens is the acoustic stack. Okay, we call it the array of the transducer. If you have fluid ingress into that, and these chemicals are nasty, some are really nasty, can get in there and destroy the probe by going through the lens. Okay, and lenses always get poked and perforated by imaging. You know, when you're doing biopsies to put in a central line or a venous, a lot of things can happen to those, and so you need to go through those kind of issues as well. As a matter of fact, it's mandatory for transesophageal probes. So here it is. The #1 cause of probe damage during an HLD, automated reprocessing, is the use of low-level wipes, i.e. user error, failure to follow IFU, or probe droppage. And a couple of those are, you know, okay, so how does that happen? Well, the transducer in the middle is a GE probe. It's an endocavitary probe. Sometimes the sonographers will take that wipe and they will just, like they're buffing shoes, you know, and that wears it down, the thickness of the lens, and can cause tears in it. When the thickness of the lens is worn and then you put it into a hostile chemical environment, it breaks, it bubbles open. We have objective evidence of that as well. That's a CT of the of the probe over on the far left side, and you can see the lens at the very top there, and then the array, and then electronics. And you know, electronics and moisture don't get along very well, and you can damage stuff here. So this is what happens to probes occasionally, and we'll go into what caused this one. And this was an epidemic for a while. They use gluing materials that can't survive a particular thing because they're not using how the OEM glued it together. So what we see is the number 2 cause of probe damage during HLD reprocessing is third-party probe repair. Okay, not using either the exact material that the OEM uses or what the FDA classifies as substantially equivalent to what the FDA uses. But you have to validate it. The third-party servicer has to validate that their probe can withstand. So you put it back into service, and you've used materials that aren't as good as what the OEM used, or don't make the same specifications that the OEM uses, you can cause significant damage.
So can you go back, please?
Yeah.
At what point do you determine if it's safe to use or not? Say in the middle, you do all your testing and all the test pass, but it looks like that. You would say it's safe to use or it's not?
Not safe. Anything that has on the lens, because that's patient contact, okay? Direct patient contact. There's electricity going up. There's electricity going up to the acoustic stack, and so you've given it both a path for electrical current to flow into the patient, and you've also given a path for the ingress of fluid back into the probe. So that would absolutely not be safe to use on a patient. Plus bugs would be hiding everywhere. When the chemicals are validated, this whole thing should be intact. If not, bugs will get in there as well, and they'll hide out, and you get cross-contamination issues. Same thing down here. Even though this probably doesn't touch the patient, there are bugs that will hide in here, but it gives a fluid ingress path into the electronics of the probe here. Oops, sorry. That was quick. Over here, so fluid comes in, gets into here, that harsh chemical is glutaldehyde or whatever, and destroys the electronics in here. This would not be safe to use. Matter of fact, they took it out of service and sent it to us for evaluation and repair. So if visual inspection is your number 1 friend, if something looks like this, you don't need a test device to tell you it's unsafe to use on a patient, because that's an endocavitary probe, okay? So the number 2 cause of probe damage, like I was saying, is third party, and it's either poor workmanship or using unvalidated replacement parts and materials. So on the lens of a probe, and all of you seen the lens of a probe, it's made from an RTV type of material, room temperature vulcanization, and it has different, and it goes into these categories of shore hardness strength. You guys heard of shore hardness strength. So this is, you go from the jelly bean candy all the way up to a tire tread in hardness. The hardness levels of the lens material, the RTV that's typically used, fall into the anywhere from 70 to 80. And that shows you what it is. So they're resilient, but they're resilient, and they've been tested to that thickness of the probe when it's initially put on. After it's been buffed off or used for a long time, it can change. And you can see what would happen if if the lens is supposed to be like this, and a third-party user uses an RTV that has a shore hardness strength of a pencil eraser, not going to last. It may not even last 1 cycle. And in that case, that was what happened here. This was a third-party probe repair here. They used a different material. The hospital sent it to us, and we ran spectrometry test on it and discovered that it was a very low short A hardness strength. And this went into a trophon device, which heats up the chamber that it's being disinfected in to 50 or 60 degrees C, and just melted the lens off of it. Okay, it never would have happened if to the OEM version of it, but because they used the sub strength materials, then that did happen to it. This is a non-OEM approved chemical that was used again during COVID. This is getting down to the area of the probe down here, the endocavitary shaft. I'm sorry, and so I've exploded that, and look at, you see the craters. I mean, those valleys and mountains are filled with bugs that never would have been able to be there had because this is entirely smooth. This right here should look like this over here. Okay, entirely smooth, uncompromised plastic finish. So pockmarked areas on the probe, that's the home of bugs. Here's another one. This occurred during COVID. We got this one in from the hospital asking, can you please repair this? We need it back in service right away, because it was being used in intensive care for the COVID patients, and they had soaked this in formaldehyde overnight, and it's not an approved cleaner for probe materials. And so this is what the probes, probes normally look like, the lens. That's what that looked like in the morning. And so, yeah, and it could not be repaired. It was totally destroyed. It got in and ate up the acoustic stack, and it had tons of dead elements in that. I know that photograph is valid because that's my thumb. If you want to compare it, it's fine. So probe materials. Who's using what? We talked about this a little bit, and here's what the OEM puts in their documentation now. They'll put down there, here's what the probe materials are. The materials, a silicone RTV. It doesn't tell you what the shore A hardness strength is. You have to figure that out if you're a third-party provider. Okay, and that's what you should always ask your third-party provider. Are you using materials that are substantially equivalent to the OEM? Yes or no? It's an easy question. Yes or no? If they say it's superior to it, now you know they're lying. Okay, so that's making a claim. But substantial equivalence, they can make that claim. And so they tell us what the materials are, but as a third-party service provider, we have to go in and do reverse engineering on all of these parts and materials and make sure the materials we are using matches that, okay? So like I was saying though, even if you're using an approved chemical, if they're not using the right materials or the right protocol, then that's what happens. So some during COVID even put the probes into an autoclave. Did it kill the bugs? Absolutely. It killed everything that was inside there a couple of times over, but unfortunately it killed the probe too. And they asked if we could fix that. We said no, but we can give it a decent burial. So yeah. You guys hear that all the time. I see it on LinkedIn all the time. We'll post it. Please fix this thing. I think just went through a nuclear explosion or something. So differences, we're going to go through this. Let's see how we're doing. Are we doing okay on time? Never. But so differences between manual and automated HLD, and we'll just go through this. And the automated reprocessors do offer advantages: consistency, traceability, and reduced occupational exposure to disinfectants. Okay, that's true, and in some cases they offer more things, more advantages. Manual processing requires careful monitoring of contact times, temperatures, and disinfectant concentrations, which can vary due to human factor, or if the human doing the test or the cleaning hasn't read what the protocol is, such as happened during COVID. And so ultrasound equipment, just so you know, can remain contaminated after manual disinfection. And so it factor that into it, cleaning. And Mark, I think you'll agree that the whole thing starts with cleaning off the macro level stuff. Has to be done before you put it into an automated disinfecting device. You blow up the automated testing device and it'll just be a train wreck. So it's still, there's no such thing as 100% automated, because you still need to do that macro cleaning of the probe, whether it's in the room where the sonographer is and is putting it into an automated disinfector, or if it's in the surgical suite for a transesophageal, clean off stuff. Remember, it's been soaking in the gastric juices for 4 hours, and when it comes out, it's very susceptible to damage because it's turned into bubble gum at that time. We get them in even with small cracks. This is why visual inspection with a 10x lube is absolutely important to have. At least do this if it's something, again, depends on what the intended use is for that device, the clinical setting. Is it susceptible to being banged, dropped? Does it have little cuts, or is it just like in a labor and delivery where they're just looking to make sure that the baby's head's in the right position? Okay. Then that would tell you how often you might want to look at the probe for a visual inspection. Okay. Or if the sonographer says, look, I dropped it, I don't know. Can you come and just take a quick look? So look around these places, because that looks like real small cut, but you can pack a couple billion germs in there, no problem. And that's a cross-contamination issue. So it gives instructions, the documents give instructions how to manually high-level disinfect an ultrasound probe. It's for the people in hospitals right now. Do you know what they do? Do you have automated disinfectant devices for probes, or is it still being manually cleaned? Anybody? Automated? Okay, great. Because they still work during COVID. They don't go home. So it's good to have those, but and so all of them have this in their manual cleaning process. There's all kinds of issues related to it, but there's still a lot of hospitals that either do it manually, do it automated, or have a hybrid for the probes, okay, depending on what their use is. And here's kind of the cycle that it goes through. Patient examination, it gets macro cleaned, it goes to HLD or sterilization. Here's choke point 1, transport and storage. A lot of probes get damaged during transport and storage, especially if they don't have the storage devices. Some of them still put them in pillowcases. No, please don't do that for 100 million reasons, but they still do. So it goes transport and storage, and then comes back. Then you have, they're selecting the gel that they're going to use, selection of the probe cover, patient examination, cleaning, and it starts the process all over again. But anytime you take something somewhere, you've got to go somewhere and pick it back up. So the transport is a two-way potential death sentence for the probe. And the other is storage, okay? And I know there's a big push on right now to not just let things air dry, like in Jerry Maguire movie, when he was air drying himself, not him, but his friend. So that was funny, by the way. You feel free to laugh. But to store these things so they don't get smashed up or broken while they're just hanging around, okay, air drying, okay? And the good high level protection. Here's kind of the inside the sonographer's room, reprocessing in the patient room is a point of in the point of care can streamline the workflow. They don't necessarily have to transport it anywhere or go pick something else back up. They may. I can't speak for 100% of them, but I know that a lot of them have it right there, so that the transport is not a big issue, but the storage can still be a big issue too. There's a temptation to just put it back in on the rack on the ultrasound machine, okay, which isn't the way to do that. So so now we're going to talk about automated HLD devices. We set the stage for that. For non-TE probes, won't get into that today. Again, time constraint. There are two basic commercial approaches to automated probe HLD reprocessing now. One of them is a company that I've been associated with for a long period of time, CS Medical. They were the first to introduce a hospital grade automated probe device. And they have two, one's for TE probes and the other one's for general probes. That's called the Ethos system. There is some plumbing required. And the other device, I think a couple of you had mentioned, Nanosonics, which is the Trophon system. It's no plumbing required, but it has other issues with it that aren't, so that's attractive, but there's also trade-offs. Pardon? Yeah, you get cut up when you work on the Trophon, yeah, and you can also get a nice burn if you aren't paying attention. So, and there's one non-commercial. I'm just going to bring this up for you, just for your edification. It's not FDA cleared. It's an approach to automated using ultraviolet rays. Okay, it works on some things, not on probes. Okay, too many places, too many shadowing and stuff going on like that. So, guidelines for automated reprocessors are, you know, the guidelines for using them are included in the original equipment manufacturer of the probes IFUs. And it'll say, if you're using those, only some transducers are compatible with automated reprocessors, okay? And so read everything that's in this, please, because the sonographer and the physician aren't gonna read those. So at least know what you're up against when you're talking about, okay, the automated reprocessors. So, and then they'll list what the following criteria is, and so you can match that with what the specs are from the companies who are making the automated reprocessors, make sure those things match. Okay, so that's really, really important to do that. CS Medical Ethos system is a picture of it there. They use, I believe, Mark, it's still just your own brand of that stuff. Yeah. So they put it in like a kind of a Keurig coffee making thing. You have that little thing in there, and you make, and wonderful coffee comes out the other end. This one, you put it in there, it gives the right amount, and you set it up for the time, the temperature, all that stuff is processed into that, and so it goes through and does that soaking job. But there is plumbing involved. I showed great restraint and taste by showing this photo rather than what I could have done with it. But yeah.
The reason for plumbing on Ethos is not only automated disinfectant, it's also automated cleaning. So without water, you can't clean.
Right.
Plus hand hygiene, soap and water.
Yep.
So you got to have water to clean steam.
Right.
Water does not clean. You don't let it clean. You're just making dirty.
Yes, exactly. Okay, so and then there's the electrical testing that goes on. So there's just some of the things on the back. I looked at it. I hate plumbing of any kind because I suck at trying to fix it. I still call in people to fix a toilet. I don't like stuff that has water on it. It's too hard. So, but I looked at this and I said, yeah, I can do this. This is not a problem. So it'll tell you what is covered and what's not covered by the warranty. Make sure you read those things so that you can keep it. Those are the guardrails for keeping your probe safe from the user. and getting the full length of time that the useful life of a probe is intended for. How many know what the useful life of a probe is intended for, that the OEMs? Okay, it's 5 to 7 years. 5 years for like a TE probe or any other very complex type of probe, 7 years for general probes. And if you just get a probe and you go outside the lines of this and you blow it up, you've done, they have done significant damage to your budget. So in terms of service options, I found CS Medical has a lot of service options. They like to work with the biomedical engineers. They have a portal on their website for service portal, and so they are good at working with biomeds. Nobody wants to send somebody in for something if especially you guys are the experts in these areas. So the Nanosonics Trophon does not require a plumber, but they use hydrogen peroxide. Yeah, they're good. 50 degrees C. I thought it was close. Inside the decontamination chamber, I've seen those opened. That lets out a lot of heat, and it puts the probe at risk, especially third-party probes who don't use the right materials, or maybe that's a good thing. Then they can't use it anymore to destroy those. And they have something as cool as called a destructor, and I thought of Godzilla when I thought of that, the oxygen destroyer, so I had to put him up there. But those things break. They use their own drops of material as well. And Nanosonics, Trophon, a couple of service points. They both kind of look at how many cycles are being used. Has a lot in common with the CT tube. How many images have you run on that tube before you start going, I need to really check this a lot more. The cloud-based remote and predictive maintenance is coming on. AI is also coming onto that. And usually that's somewhere 5,000 cycle. They say have a major service and stuff like that. So read what those are. They do fail. This happened with a Nanosonics, some clinical engineering. They always send it to clinical engineering. You see, that's why I had to highlight that. even if you didn't know you were responsible for it, they go, send it to the clinical engineer. They'll fix it up. How hard can it be, right? So to look at these adverse events, and do you guys get routinely published adverse events list like once a month or something from all the stuff that you're in charge of?
Yes.
Or do you have to go look for stuff? Okay, good. Okay, and then lastly, we're running out of time, the LumiCare 1, that's UV. It's not for sale in the US. There's a lot of reasons for that. The sun produces 3 wavelength ranges of UV light, and the problem with it is probes are like, they produce shadowing because of the indentations in the probe. So you can't get a homogeneous exposure to the ultraviolet light when you use a probe, or really any device that has little nooks and crannies in it like that. It'll produce shadowing like shown on the right hand side. Just showing that. So the key takeaways, and then any questions that come up. Survey all the steps that HLD reprocessing is done for probes in your facilities. Show where the gaps are in the various departments using ultrasound, because you could have, you could have a device in central processing and one in radiology, one in cardiology. I mean, there could be multiple. Is everybody using it the same way internally? Is Spalding used? And then manual or automated devices, servicings and PMs. I have information on all those, and then what to watch out for in saving probes from early death. Visualize those that are used in a clinical procedure that exposes it to biopsy needles or close quarters with any kind of metallic or hard ceramic where they can get broken, and deceleration trauma as well. Okay, any questions? Covered a lot.